Welcome to Dismantling Medical Gaslighting from Within, Understanding Medical Invalidation, a lecture developed and presented by myself, Caitlin Kelly, Physician Associate. So who am I and why am I talking about medical gaslighting? My name is Caitlin Kelly, and I'm a Physician Associate and proud graduate of the Jefferson College of Health Sciences program in 2010. I am also the author of The Secular Prayers of Medicine, Stories from the Front Lines, a fictionalized case series in which I take the most interesting cases from the first 10 years of my practice and talk about what really happens when patients are medically gaslit or dismissed. I'm a survivor, and you might notice the photograph on this slide is me, and that's when I was post-op from a vascular compression repair for MALS. For decades, nearly 35 years, I sat by as my doctors and then my colleagues dismissed my symptoms, calling them psychosomatic, which is precisely why I talk about gaslighting, because it was never psychosomatic in my case, and chances are you may be missing some physical pathology from your patients if we hang our hats on mental illness without doing an evidence-based workup first. During the course of today's lecture, we're going to have three major objectives. First, you're going to learn how to identify and define the differences between medical gaslighting versus invalidation, so you can identify it and stop it in your practice. You're going to learn how bedside manner can contribute to medical invalidation for patients, and we're going to deconstruct 3 case studies in which patients reported gaslighting and see how we can do better. And we really can't have a conversation about gaslighting without going through some basic definitions first. So we're going to start our definitions with implicit bias. This is also known as implicit prejudice or implicit attitude. And it's a negative attitude of which one is not consciously aware against a specific social group. Now, implicit bias may contribute to healthcare disparities by shaping clinician behavior and producing differences in medical treatment along the lines of race, ethnicity, gender, or other social factors. So how does implicit bias show up at the bedside? Well, it can be pretty ugly, and it can sound like some of the quotes I have listed here on this slide. How many times have you ever heard certain patients have higher pain tolerances than others? Have you ever heard of the idea that a female provider or a male provider may be better than their counterpart for whatever reason? Have you ever heard somebody assume that a patient must be uneducated because they are below a certain economic line? Or perhaps the most common one, fat bias. Somebody assuming that an overweight patient may be lazy without getting to know them. Implicit bias should never, ever make it outside of our heads and into the exam room. But by naming and acknowledging that these are real conditionings that we all experience, we can start to dismantle it. The word of the day is gaslighting. And gaslighting is the psychological manipulation of someone into questioning their own sanity, powers of reason, or lived experience. It was introduced into pop psychology by Dr. Robert Stern, author of The Gaslight Effect, and he describes it as a form of emotional abuse. But it actually is derived from a 1938 play, Gaslight, by Patrick Hamilton. It was later adapted into movies in 1940 and 1944, and it follows the story of a husband and wife, in which the wife slowly starts to question her sanity because her husband is dimming the gas lights in their house, but lying about it. So what does it look like in a medical context as opposed to a pop psychology context? Gaslighting in an everyday context is going to follow a very similar pattern each and every time. It's the deny, deflect, and manipulate pattern, and it can be subtle. So on this slide, I've included a couple of quotes that you might hear and how they correspond to gaslighting in general public. So they're going to deny it. That never happened. The event just didn't happen. You're too sensitive. That's dismissing valid emotions with a single sentence. You're imagining things is going to make that person think that they're questioning their lived experience, and you're crazy straight up is going to undermine their mental stability. If we reach for that phrase, you're overreacting, we're also instilling guilt. So again, gaslighting is going to follow a deny, deflect, and manipulate pattern whether it's in general context or in a medical setting. Let's add a little spice. What is medical gaslighting then? So medical gaslighting is when a healthcare provider dismisses your concerns without offering an evidence-based workup and hanging their differential diagnosis on psychological factors. It's all in your head. And if you're telling a patient that their diagnosis is all in their head, you better be damn sure you did the appropriate medical workup. Because if you didn't, then you are gaslighting your patients. And how is this going to show up with those quotes that deny, deflect, and manipulate? Well, on this slide, we can take a look at it directly together. If you say to a patient, "Are you sure that really happened?" you are denying the event and questioning their reality. You gotta trust what the patient is telling you. You can dismiss emotions very easily by saying you're too sensitive about a particular symptom. And something to you, which may be no big deal, might be life-threatening to that patient. So hold space for their emotions. You're going to question lived experience if you ever suggest that they're imagining something because they saw it online first. Dr. Google is a consult to be taken with a grain of salt, but you really want to encourage the patients to work with you and the tools they have before outright dismissing them. You're going to undermine their mental stability. If you hold your hat onto the fact that all your tests are normal, it's impossible for you to have that diagnosis. Get curious with the patient. Don't assume. And then try to avoid instilling guilt by ever suggesting that a patient is overreacting or insinuating that they would get better results if only they were more compliant with X, Y, and Z. And don't get me wrong, I don't really think anybody goes into medicine with the intent to hurt their patients. After all, we made a promise of do no harm. And I truly believe that we should never assume malice when ignorance suffices. And as clinicians, it's our job to learn about gaps in our knowledge so it doesn't affect our patients. And so if we're capable of making mistakes, does it automatically mean we're gaslighting our patients anytime they feel dismissed? No, I don't think that we are intentionally automatically gaslighting our patients every time we make a mistake. And neither does Dr. Alexandra Fuss. She is the lead author on the article, "We Didn't Start the Fire, or Did We? A Narrative Review of Medical Gaslighting, an Introduction to Medical Invalidation." This was published in 2024 in the Translation Gastroenterology and Hepatology. And Dr. Fuss is an instructor at Psychology Harvard Medical School and the Director of Behavioral Health and Inflammatory Bowel Disease at Massachusetts General Hospital and their Crohn's Colitis Center. She wanted to look into gaslighting more, and she proposes an alternative word that makes a lot more sense, because I don't think any of us are intentionally doing harm. Because here's where we get to our second word of the day, medical invalidation. Intent matters. Dr. Fuss and I both agree that medical invalidation is the unintentional dismissal of patients during encounters. And this can happen for a variety of reasons, and we're going to explore a whole bunch of them together. But intent matters, and once we're aware of these dynamics, we can start to change them. So now that we understand the nuance between gaslighting and invalidation, what do we do about it? Well, Dr. Fuss had this phenomenal quote in her research, and I want to share that with you today. While providers have expertise in the management of suffering, patients have expertise in the experience of suffering. That makes a lot of sense. We want to collaborate with our patients because they are the one experiencing the symptoms and the pathology. So I created a term called scale or scale back that reminds you to check your own pulse before you start to go off on a patient for whatever reason. And I quote it as, "In order to best care for our patients, before we do anything else, we must stop so we can collaborate with our patient by actively listening." Scale back before you talk back if you're triggered emotionally for whatever reason. So when do we use scale back? We use scale back before we enter an exam room that we know is going to be challenging. We use it to stop ourselves before we act on bad behaviors. Again, scale back before you talk back. Patients are going to trigger hot emotions sometimes with you, and we want to avoid transference. And providers that are successful are those that can practice self-regulation. So ask yourself, do you need a drink of water? Do you need to go to the bathroom? Have you eaten anything today? Take care of yourself before you take care of others. Because if we don't check our implicit biases at the door, we are intentionally doing a disservice to our patients, and that crosses the line from invalidation into gaslighting. And we made a promise, do no harm. Let's say a patient has accused you of gaslighting them or they feel invalidated. Well, what exactly does that look like, and why would a patient have that perspective? Invalidation can take a lot of subtle forms, and they can be as simple as constant interruptions, whether or not the provider gives them more than a moment to speak their mind, or a knock on the exam door, getting the provider to leave the encounter for whatever reason. Active listening is key in preventing invalidation, and if a provider is unable to actively listen, make eye contact, take time to mirror what the patient said to them, things are going to get lost in translation, and patients are going to pick up on that cut corner. Rushed or double booked appointments are a real issue, and most of us have no control over our actual clinic schedules. So it is important to put pressure on the healthcare administrations and the organizations that are responsible for scheduling us. If we have a private practice like I do, it is important to avoid double booking. Microaggressions. Now, this is where things can get a little bit dicey. We are not always aware of rolling our eyes or a little nod of the head that can seem dismissive. But patients who are already emotionally primed for a confrontation might pick up on physical microaggressions that you're not even aware that you're doing. And again, at the end of the day, that invalidation versus gaslighting comes back on whether or not you're dismissing them with an evidence-based workup or without one. So why are we doing this? Why are we falling into these traps where we're invalidating our patients? Well, Dr. Jonathan Maron, the director of the Harvard Medical School for Bioethics, has some ideas. And he suggests there are three main reasons why healthcare providers are going to trip into invalidating their patients. He is quoted as saying, "The healthcare provider might have poor communication skills or limited time to speak with a patient, or may not be medically knowledgeable to know what to do." And it's really hard for us to acknowledge our knowledge gaps. But as you can see from this presentation, it is literally part of our job, and it's the bare minimum that we should be doing. Why does addressing invalidation matter? It matters because it's directly tied to our patients' outcomes. Patients who have bad experience in medicine generally aren't going to return, and then they might seek alternatives that put them at higher risk for complications. We lose trust with our patients if we constantly invalidate them, cut them off, dismiss them. And if they don't trust us, who are they going to trust? They're going to become lost to follow-up. This is going to result in delayed care, which can progress to disability and death in some situations. This is going to be especially an issue for individuals who are marginalized. This is our BIPOC individuals, our LGBTQ plus individuals, our women and our low socioeconomic statuses. These are the people that we are charged to protect, and we're failing them unless we acknowledge our issues. Medicine is not practiced in a vacuum, and no one individual can combat systemic injustices, which is why when we combat medical invalidation, we need to do it on a healthcare administration, patient level, and provider level. Now, whether or not we can actually influence our organizations to do this is yet to be determined, but healthcare systems can combat invalidation by providing training, much like the training that you're listening today with my lecture. They want to mandate diverse representation at all levels of healthcare. So that includes our BIPOC or LGBTQ plus individuals working alongside us to ensure everyone is equally represented. There needs to be clear, established consequences for clinicians that not only invalidate, but persistently invalidate to the point where it's a pattern of gaslighting. And we need to hold our peers accountable. Likewise, we must have resources for moral injury and burnout for clinicians. We are cogs in a machine, but we need to be well maintained. And then part of this is strong staffing and mandated breaks, right? Unsafe staffing ratios kill patients, and they also kill providers. So let's start getting loud about some of the things that we expect our healthcare systems to do for us, both as patients and providers. I spend a lot of my time teaching seminars to patients, specifically rare disease patients. As someone who went through the medical system first as a young child with a rare disease that was ultimately misdiagnosed multiple times, I really want my patients and my people to feel like they can advocate for themselves in medical spaces. So this is what I teach my patients to do when they go see a specialist or a new provider. I tell them to buddy up. Always bring another pair of eyes and ears. Having another person in the room not only ensures that you understand what's happening, but it also acts as a barrier to prevent poor treatment because someone is witnessing it. You want to journal your symptoms and have a pretty clear HPI before you even walk in the door. That way you can engage in the time that you have with your clinician in a meaningful way. Bring a written list of questions. This is especially helpful if you really don't understand what's happening. You're there to get help from the provider, and the provider is able to do that so much better if you have a set of questions. You can also ask your provider if they feel comfortable audio recording the encounter. Now, not everybody will say yes, but my thought process is if we as clinicians are starting to use AI to optimize our notes, why can't our patients also use audio to process what they learn with us at a slower pace at their own level? Finally, I also encourage my patients to follow up with their clinical team utilizing patient portals or their electronic health records by doing written questions right there in their medical record so that they can stay connected. Continuity of care matters, and patients can play a role in their own continuity of care this way. And that brings us right back to us, the clinicians at the bedside. How can providers combat invalidation? Well, you're doing it, like I said, just by listening to this lecture and by being aware of your own knowledge gaps. You're going to be able to build trust with patients over time. So don't assume that you can jump right into heavy-hitting conversations the first, second, or even third time you meet somebody. You want to believe them. Don't make them question their reality. Everything they're coming to you with, they have a reason. It's just sometimes kind of hard to understand those reasons. You want to collaborate with the entire treatment team. So if the patient is seeing a surgeon or a nephrologist or a cardiologist, make sure you read those notes. Be informed before you try to form a medical opinion on a complicated patient, because they're going to know if you're cutting corners by not reading through those consults. And one thing that I do in particular is I try to mirror the language of my patients. I use thoughtful communication to summarize everything they've told me while also informing them what my treatment plan is. And you always want to finish a consult with the opportunity for patients to ask questions and get clarity. We throw a lot of information to our patients all at once, and it's not unusual for them to only obtain maybe 20% of it, if that. So you can combat invalidation by giving them time and practicing trust. It's time to get into some case studies. So we're going to start with a really common case study, declining a medication, right? Patients will sometimes come into the practice with a intent of what they want you to prescribe them, and whether or not they actually need that medication, to be determined. GLPs are kind of the hot topic right now. But whether this is a GLP-1, a narcotic, an antibiotic, or anything, we need to be able to have clear and concise conversations with patients about why we would decline to prescribe a certain medication. So this case is an example of something that happened in my primary care practice, in which a 72-year-old man presented wanting to get a prescription for some Ozempic to get rid of his pot belly. This gentleman, his past medical history was pertinent for pancreatic insufficiency, and he was notoriously non-compliant with taking his enzymes or following up with his specialists. He had a thyroid nodule, he was HIV positive, some anxiety, some high blood pressure, and again, not the most compliant individual. Well, during the encounter, the provider took a look at his BMI, which was only 21, an A1C of 5.4%, no history of fatty liver disease, no history of sleep apnea, no good reason to prescribe a GLP-1 for the patient. And the doctor said, GLPs aren't for people like you. And the doc thought that was the end of the conversation. Except the patient took it in an incredibly different way, one that wasn't entirely expected. So when the patient did go ahead and put in a complaint for being gaslit, we knew we had to dig a little deeper. So the patient left his encounter furious. He actually stormed out of the office, but he didn't leave before he went ahead and he put in a formal complaint alleging gaslighting for the provider. He threatened to transfer to a different provider. He threatened to never come back to the clinic again. And the reason why makes a lot of sense if we stop and think about it. He's a 72-year-old man who's HIV positive. So if we start to unpack the emotional baggage that the patient is bringing into the room with us, we know that they're an entire person with a life outside of pathology. You ever wonder what it might have been like for a young man in the 1980s to be told he was HIV positive? When I spoke to this patient, he shared his story with me. He shared how when he was diagnosed with HIV, he was told in a clinic, you're just going to die anyway. So flash forward to now, when this gentleman wanted to address his pot belly, and he heard, it's not for people like you. The emotional triggers that he experienced wasn't anything that that doctor could have guessed about. But if we slow the temperature, ask questions, get curious, engage the patient, why are you reacting this way? Hopefully, we can dismantle that invalidation in real time before they even leave that office. And so the more questions I asked this patient about his experience with being invalidated over getting a drug denial, the more I was able to understand. So some of the tools that we can use when we're denying a drug is to get the patient to understand where we're coming from. You want to deconstruct pharmaceutical advertising. They have fantastic advertising, and it's no wonder that patients are coming in asking for things by brand name. But again, it's our job as a clinician to explain, because of the pancreatic insufficiency, because of the risk for pancreatic damage, because your BMI is not elevated, because you don't have these medical conditions like sleep apnea or fatty liver disease or type 2 diabetes. Once I put it into the context that you're not a good choice for this medication, not because of you as a person, but because of your comorbidities, the patient started to understand. I also wanted to empower him, and you want to empower patients on their level by using language that they understand. So don't speak all the way up here in medical mumbo jumbo, Harry Potter talk. Talk to them the way they talk. If they have a 5th grade reading level, speak in a 5th grade reading level. If they're college educated engineer, speak to them like an engineer. Put it in context of how they would understand. And at the end of the day, connect them with tools that will get them to their goal. He was concerned about his pot belly. He saw some really great commercials that thought, I can get rid of that pot belly. When in reality, his insurance would actually cover a consult with a dietitian. And that's a much more healthful and long-term goal that we can actually achieve together. So let's switch gears and launch into our second case study. This one, the title actually comes directly from the patient because she feels like she experienced drive-by judgment. And I think that's such a powerful phrase. So what do we do if we have a patient that's thrust onto our schedule and we're not used to them, they're not used to us? We might feel frustrated, we might have some of those emotional triggers come up, which is why it's really important to use that scale back method, right? Check your pulse before you go in and chat with the patient. Now, in this particular case, we had a 39-year-old woman that was meeting a new to her provider as part of a preoperative exam before a rotator cuff repair. Now, this patient had a history of obesity. Her BMI was 37.4. She had some high blood pressure, some diabetes. Her A1C wasn't that great at 8.8%. Some high cholesterol, some anxiety, and of course, that torn right rotator cuff for which she was presenting. Now, the patient did go ahead and put in a complaint after meeting with this provider because she felt like she received a lot of judgment for seeking medical and surgical care. According to the patient, the provider had repeatedly said, "Are you sure you really want to be doing this surgery? Are you sure you really need this surgery?" And they also went ahead and insinuated that they would not be doing that surgery because the A1C was so out of control. The patient didn't feel like the provider was listening and was really, really worried when they left that their preoperative exam was going to be denied. So what do we do? Now, what's interesting about this case is the patient didn't say anything at all during the exam. In fact, they described that they were a little bit too clammed up to say anything at all because, one, they didn't want to offend the provider, and two, they were afraid that they were not going to get their pre-op certification. So what did the patient do in this situation? They stayed in the room. They listened to the recommendations that were made for them, but then they went home and they cried all night. And the patient described it as being invalidated and judged without being given the opportunity to talk about who they are, where they came from, or the progress that they've made in regards to their weight and their diabetic management. I'm going to read a quote from this patient with her permission. She had said, "I've been fat my whole life, and I've never felt so small as when she spoke to me. I know I'm fat. My surgeon knows I'm fat. I just need my arm back." So what exactly did the provider do that upset the patient so very much? The patient stated that the provider rolled her eyes multiple times during the encounter when patients started to speak up regarding her diet and exercise regimen, casting a sheen of disbelief that just soured the entire appointment. Because she felt like she was rolling her eyes and was scoffing, she didn't feel like she was comfortable continuing the conversation, so she clammed up. The provider repeatedly told the patient that she needed to take her condition seriously, and if she didn't take her condition seriously, she would be at risk for disability and death. Now, this is true. If we have uncontrolled diabetes and uncontrolled obesity, we are at risk for bad outcomes. But I really want us to use that scale back method to stop and think about some of those emotional triggers and think about how they affect us at the bedside. It's easy to have drive-by judgment if we're just rushing through an appointment on somebody who's slipped into our schedule or someone we're not familiar with. But we got to take that time to learn about the patient, and in this case, to learn about how she got that shoulder injury, because it is important. Because if that provider had taken the time to get to know the patient first and asked them, "How did you get that rotator cuff tear?" they would have found out that that patient had gone ahead and joined a gym, joined a weightlifting class, a swimming class, and it was actually an exercise-related injury. They had spent the previous 8 months trying physical therapy, weight loss, and getting their sugars under better control before they would proceed with surgery. So she was flabbergasted by what she called that drive-by judgment. There was no context for how far she had already come. When you're faced with a case like this and you're not sure if you want to sign off on them, consider, what about the other specialists on the team? Is the surgeon worried about it? And when I asked this patient, was her surgeon worried? She said no, he wasn't worried, and he had been following her for those last 8 months and was proud of her improvements. I validated her emotions. What she experienced at the bedside was unfortunate and unnecessary. And with her permission, I included her in this presentation. Because patients should always be advised of their rights. They do not have to be locked in with a provider if they feel like that provider is disrespectful or not in line with their values. They have the right to lodge a formal complaint and to talk to somebody in management. This patient was very polite. They didn't storm off, they didn't cause a scene, and they were appreciative of the time given to talk about their concerns and figure out a path forward. Because no one should experience drive-by judgment, even if they do have an extra pound or 2 or 10, like I do. Now, I call this last case study number 3, let's just wait and see. Anyone that lives with a rare disease absolutely abhors that statement. And while observation can always be an appropriate approach in medicine, we want to make sure we understand an average versus above average risk patient. So this particular case comes from a 46-year-old woman in my practice that has Lynch syndrome. She has a history of pelvic fibroids, a renal mass that's benign, some pancreatic cysts, and a history of basal cell skin cancer. She also has a lot of anxiety. Now, I saw her for her annual physical, and during that physical, I appreciated a fleshy papule on the top of her ear that had only just sprung up in the last 4 weeks, but I wanted it biopsied because of the Lynch syndrome. So as a good, dutiful primary care provider, I went ahead and I put together a referral, and I explicitly explained to the dermatologist because of the Lynch syndrome, we wanted this biopsied. It was a high-risk patient in a high-risk area. Now, the patient waited politely and patiently for her appointment with dermatology, expected a biopsy, but when the dermatologist looked at her ear, she said, "Oh, that's nothing. That's just age, just an age spot." The patient said, "Well, I'm here for a biopsy." The dermatologist pushed back and said, "It's impossible for skin cancer to crop up so fast. Let's not be so hasty to biopsy." Well, this was not this patient's first rodeo with specialist as a rare disease patient, and what she did next is a great example of how to advocate for yourself as a patient. So this patient advocated for herself in a really, really powerful way that I teach my patients how to do. Whenever you are faced as a patient with a specialist that doesn't want to order a test for whatever reason, ask for their clinical reasoning. Be part of the conversation. And if the specialist still doesn't want to order the test, you can drop a statement like the one my patient did. Will you document why you are declining to proceed with biopsy today so I can get a second opinion? So what did the provider do in this situation? She did that biopsy after the patient dropped that quote. But what she didn't do was take the time to read my letter, my referral letter, where I detailed the risk factors of Lynch syndrome and why I understood it was unusual to biopsy after only 4 weeks for an average risk patient, but that's not what my patient was. And for those of you unfamiliar with Lynch syndrome, it is a relatively rare diagnosis. It is an inherited genetic mutation of the NMR genes, which follows an autosomal dominant pattern, and it drastically increases the risk of cancer before the age of 50. The biopsy was positive. So with a positive biopsy, you can imagine how that specialist felt because they first advocated for that wait and see approach until the patient politely and professionally pushed back, asking for their clinical reasoning. Now, I was very impressed because the dermatologist did go ahead and take personal responsibility. They called the patient directly as soon as they had those results and let them know that, yeah, they were correct. It was, in fact, cancer. It was basal cell, actually. And the patient really appreciated the provider taking the time to call them personally and to not only apologize for their kind of hasty decision to observe, but also gave that provider the opportunity to ask questions about them and to learn about Lynch syndrome. Because I don't care who you are or how long you've been practicing, if you are faced with a rare disease and you have them in your office, please take the time to get to know them. Learn their story and their face, and I promise you, you will never miss that diagnosis again. We have to learn how to acknowledge what we're lacking, and we need to thank patients for the sacred right to get to know them and to get to treat them. So when we have somebody who is denying a test for whatever reason, deny the test if it's an evidence-based reason. But if it's just a matter of time or frustration dealing with prior authorizations or some barrier that's not a medical barrier, go ahead and order the test. Your rare disease patients will thank you. Hopefully by now you understand what medical gaslighting versus invalidation is. You're able to see these case studies and identify gaps in your knowledge, and you're ready to tackle some pretty uncomfortable conversations, both with your patients and with your colleagues. But I'd like to leave you with a few quotes or easy scripts that you can reach to. Years ago, when I first started writing as the Write Assistant online, I was a copywriter. And my followers would quote me as, "What would Caitlin say?" Because I'd create scripts for difficult conversations. So I want to leave you with a couple of quick scripts. Scale back before you talk back. Stop so you can collaborate with your patient by actively listening. If you want to table some high emotional talk because you can tell that the patient is not ready to continue the conversation, the way that I like to do it is with the following quote. "I'm always available to discuss this at a later time. No judgment, only information." By using the phrase "no judgment, only information," I find it a quick and easy way to calm any fears that the patient might be judged, while reminding them that I am an open source of information for them specifically. This is especially helpful in vaccine conversations where people might be hesitant. And again, you want to get to know somebody before you make recommendations that they might balk at. I also really like to follow that statement up with, "My job is to offer you evidence-based recommendations and then document your decisions." Because as a primary care provider, I cannot, nor should I try to control you entirely. We're working together as a collaborative team. Now, what if you don't know something? A patient asks you a question, boom, what's the answer? Well, we're human. We're not ChatGPT. We're not going to spit out an answer immediately. But you can go ahead and acknowledge that knowledge gap in real time by saying something like, "I don't know enough about that topic to give you an opinion on it yet, but I will look into it for you." And then you better look into it. And then if you don't know what to do next, acknowledge that. You can say something along the lines of, "I'm right there with you in your frustrations, but I'm not giving up on you, and neither should you. We're going to keep working on this together." And always say thank you. Thank you for the opportunity to learn about the patient, the pathology, and just to be a part of their lives. So thank you for this opportunity. And that's a wrap then on my lecture on dismantling medical gaslighting from within, understanding medical invalidation. Again, my name is Caitlin Kelly, and I would love to connect with you. You can find me on LinkedIn, or you can email me directly at thewriteassistant@gmail.com. You can find my alter ego, The Write Assistant, on Facebook and Instagram, or you can go ahead and get a copy of my book, The Secular Prayers of Medicine, Stories from the Front Lines, on Amazon, Barnes & Noble, or any major retailers. If you'd like to do a deep dive into why I do what I do and what it's like to be a physician associate living with a rare disease. I'd like to end my presentation the way that I end my book, by reminding all of us that when hypotheticals happen, we always deserve dignity. Thank you.